Thank you for inviting me. So this was very interesting for me because it's not an issue I was working on anyway, so this gave me an excuse to work on it, although no one is really paying me for it. So a little bit, but it ties well into my background. So I worked a lot on bioethics with special concentration several times on applications from genetics in medicine, especially actually testing of different kinds. So, and recently this kind of development in the specific area of prenatal screening programs. So there's a lot of development there as well, as you might know. But I'm also quite engaged in issues around priority setting and rationing of and resource allocation in the Swedish system of this. So I tried to put together things that I was thinking about, especially then for this event. And so thanks again. So I'm going to do some basic assumption, nothing deep. So I'm thinking about not only genomic medicine, but the way the strategies, several of them have been presented here, put together clinical resources and research resources. And the way that they are also set up to feed into both clinical practice and research. And also there's a repetition of this idea of translation, namely to have research much quicker translate into clinical use and utility and so on. So this is the specific thing I'm going to talk about. Now, I'm not sure that every one of the models that have been sort of presented here today falls into this category, but I think all of the models has something of this into them. And I think that this way of thinking about it is also a way to clarify some of the ethical issues around this. Now, the basic thing from me, from a resource allocation ethical standpoint, is that this thing costs a lot of money. So there's a lot of resources being pulled into building up these new institutions and new arrangements, right? And in order to be able, a minimal thing you need to be able to do to justify this is to say that they can at least balance their opportunity costs, these things. However you measure the benefits and the costs. So however you do that, you need to be able to say that what we get from this investment is a benefit that can justify that we don't invest in another benefit. So this is the classic standpoint of all kind of health economic assessment as well, but it also goes very well with ethics. And inside this structure, you can then discuss what should count as a benefit, what should count as a cost, how should these balancing acts be constrained and done in various ways. So all the discussions that have been hinted at today, that there's an issue here of how we should measure and define the benefit side of genomic medicine. So whatever idea you come up with there, you have to have an idea that allows you to do this horizontal comparison to alternative investments. Otherwise, you have a useless tool. So there's no point of having a health economic tool that only tells you about the investment you're actually doing, that this might give you more benefit than cost. You need to be able to compare to the alternative investments, right? And then you can put in all the kinds of values you want into this. But the important thing is then that you evaluate all the options in the same way. So if you're going to measure these kinds of non-health values that have been taken up several times, for genomic measures, genomic medicine, you also have to measure it for other things that genomic medicine is competing with, right? So this is the basic thing that comes in. And you can achieve a lot with the ethical tweaking here of these parameters, and I think there are some well-known examples here. So all countries, I think, have this sort of orphan disease schemes where we, for ethical reasons, allow on paper very costly and effective treatments to enter our systems. So we have a willingness to pay that is not economically justified, it's ethically justified. So we're saying we're going to pay for this really enormously expensive treatment for this rare condition because you shouldn't be punished in the system just because you're unlucky to be hit by a rare disease rather than a common disease, for instance. That drives up the price. Or to flip it around, the well-known example for all you Brits here, the UK Cancer Fund, where you can instead flip it around and have a criticism on ethical reasons. So saying that, okay, so it's very attractive, everybody yells cancer and you want to throw money at it, but when you actually do the comparison, from an ethical standpoint, you can start to question the thing, although of course the need of cancer patients is a valid need. But there are also these other patients then who don't get the resources that are now put into the cancer fund. So that's an ethical problem rather than an economical one. So that's a few examples. But so this is the thing that's the sort of the basic assumptions I'm going to do, as I'm very open with what kind of ethical values we can put into this sort of horizontal comparison you need to do in order to justify a healthcare investment. So over to this translational genomic medicine then. So I'm going to sketch what I see to be two basic models here. And I think we have seen a little bit, at least of the first one, in several of the presentations in this area. And the first model is the idea of having what I call the lab assist in the clinic model. So you have a research setup, a research lab, basically, with a database and all these kinds of things that you use in the research. And then you have clinical healthcare that can send questions to this specific thing that you set up in relationship to, and then you get answers back. And this lab can answer questions that your sort of ordinary facilities cannot answer. This is the whole point, right? So you have your standard diagnostic lab, but they can't answer these questions. This is the value, right? And there are like two variants here that you do this. So I know one thing they do at Karolinska Hospital is this first, where now and then you have these non-standard patients popping up. Strange, symptomatic clusters. You don't know what it is. You don't know what to do with it. And then you go for a hunt, for a diagnosis. And if you're really lucky, you can also cook up a new treatment for it by consulting all your databases and so on. So this is one thing you can do. And this is something that you can't really predict. These patients, you know they appear from time to time, but you can't predict when they come. Then you have the other version, which is more in the personalized, when you have an organized precision medicine routine, like a pharmacogenomic tailoring of cancer treatment or something like that. So you know that you will always have a known uncertainty that the research facility in the clinic, so to speak, can help you with straighten out a little bit. And hopefully then you can have a better treatment coming out of that. So these are two. This is one model then of translational genomic medicine. And the whole point is this, that the thing in the middle is something that is not a routine sort of standard part of the health system. So you move the research resources into the health system to make use of them in the health system, to have health benefits. The other one is to flip the coin then. You have still moved a research lab into the clinic, but now the aim is the opposite. The aim is to further research by exploiting then the resources of the clinical healthcare that you have there. And the resources are, in this case, the patients, of course. So they are research subjects that you can use. And it's much easier to do it if you have a research lab in the clinic. And this can be done in different ways. One way is this, that you now and then you have this interesting patient and you sort of grab them in the process and you experiment. Basically, you take tests that's not really clinically motivated, but they could give interesting results. You might even try to treat them, right, experimentally, because so these are non-standard patients. Your normal test and treatment doesn't work so well, so here you sort of grab them into this situation. Or you can even think that and I have some American colleagues that have been discussing about this to say that, well, we need to rethink research ethics and clinical ethics and the sort of the borderline between them, And we need to be more allowing of having a research situation in the midst of the clinical situation, and actually allow, because at the end of the day, also in the clinical situation, we allow ourselves to experiment a little bit with our patient in an empirical healthcare situation, for instance. And then, a lot of the time when I talk to the people who sort of run these operations or want to set up them, what appears to me is that it's unclear whether or not the idea is this or this. The aims, they seem to be a little bit of both, right? So the aim is here that, okay, so, well, we set up this thing, and hopefully it can do some clinical good now and then, or in a sort of orderly way, but we also believe that it can further research and knowledge development and so on and so forth. So if you're going to look for the value here, it's sort of unclear where you're supposed to find it. And it's always problematic from an ethical standpoint when the aim is unclear, because then you don't really know what can justify the downsides of the operation. So one thing then from an ethical standpoint is, I think that basically you always need to clarify what exactly is the aim. And if you want to mix different aims, where maybe different kind of ethical rationales apply, you need to clarify very well how these are going to mix, right? But I'm going to look at them in this boring philosophical analytical way, take them one at a time. So, so here we have the first one then. So first of all, cost is considerable, so we need to justify the cost. This is the first time. Okay, so in this case, when the idea is that the lab is assisting the clinic, the benefit should be in healthcare terms. So you look, and then, I mean, this has already been covered today, that here you have a big problem to actually be able to demonstrate the benefit. So, especially since it seems that there's very little research being done with controls here, as several have pointed out. So how do you demonstrate clinical benefit? I mean, you could have historical controls if you have really good registries and these kinds of things, of course. So you could try to do that, and I'm not sure how much that is done, but that would need, if this investment is going to be justified only with controlled series observation studies, I mean, I think it has to be really neatly done research in that case, because it's a huge investment. It's also the case that the whole idea in a lot of these operations is that you find this unique patient, you find the unique problem that this person has, you tailor this specific treatment for this particular person. You might not see a patient like this in the next 25 years. Because now you're dealing with all these small differences between individuals. And this makes it very hard to, even in theory, prove a causal link between what you do and what comes out of the treatment. Because our only way to proving causal links is through statistical clusters. So there's an epistemological problem at the heart of this if you're going at it in this way. So that has sort of moved me to think that, yeah, and then of course, even if you restrict this kind of setup only to very badly off patients that really lack good treatment alternatives, it's of course still true that you can harm them. So this is often forgotten. So even if you're on the brink of, you stand at death's door, basically, I mean, you can still be worse off due to an experimental treatment, as the case of Macchiarini shows, right? But then maybe we shouldn't think about justifying actually the intervention. So my whole idea is that to justify a diagnostic investment, it has to be tied to some kind of intervention that produces a clinical benefit. But maybe we shouldn't look at this intervention for intervention, patient for patient, and then add them up. But rather think in terms of the entire package. So you rather test the concept. So how could you do that? Well, okay. So then you rather move, okay, so then you should look at this whole circle figure up there as an experimental thing. You do. The entire thing is the intervention. And you need to compare that to something else, where you do things differently, in order to show effect, right? So, and I think that's possible to do, but then you're moving more into the other variant when you have clinical healthcare serving research to prove something from a research standpoint. And I think that, so you will still not have very much of clinical benefits that you could use here to justify the cost from an opportunity cost standpoint, because we all know what this competes with. It competes with a lot of other areas where you have lots of patients, lots of well-proven treatments that you could fund more of, and so on and so forth. So this will be difficult in that way. But if we move, we maybe instead think that, okay, so the benefit might be not clinical here. Now and then we might do some good, but that's more incidental. Maybe the big benefit here is actually that this is a big research project, and the benefit should be the research output. So then we move to the next model. Again, cost is considerable. There's really no healthcare benefit if you view it in this way. It's all a big experiment. Or if it is one, it's very unclear, uncertain, and so on. And in the individual case, this to the price of uncertainty and risk and so on. And there are, of course, certain problems here from a sort of healthcare ethical standpoint, as the case of Macchiarini and similar operations has been done, I think, both in the UK, I think, and in Germany, is very controversial things. Is that when you set up this thing, is that you have a normal healthcare situation where patients expect that what they're going to be offered are well-researched, evidence-based treatments. And suddenly says to them, okay, you're really badly off, but we have this experimental thing. But you don't offer it. I mean, so the whole idea with this kind of thing that, for example, Macchiarini ran was not then to say that, okay, so we're going now to have an informed consent process, we're going to carefully explain to you all the risks and benefits and the alternatives. We're just going to say, so this is the only hope you have, basically. You can take it or leave it. Then, of course, you maximizes the risk of one of the most basic problems in clinical research, the therapeutic and misconceptions, that patients don't understand that they're entering an experimental situation. Because they're still assuming it's standard healthcare, although it's precarious. And then it violates, of course, the standard research exceptionalism that you find in the Helsinki Declaration and so on. And it violates standard informed consent requirements. So then you can, in order to avoid that, so if we look at standard healthcare ethics as a kind of a normative constraint on how you should do a trial here, you must conform to that. Then you can organize the whole thing, thinking about organizing as a clinical trial. So you could imagine here sort of, so let's say that NHS England has this. NHS Scotland has business as usual. And then you compare them, and you run them for, I don't know, it's a lot of people, so maybe you don't have to run for such a long time, if you have really good measurements and so on. But then you actually will have an RCT that could prove effect, and then it might turn out that even if you can't really prove effects in individual cases and then add them up, you can actually prove effect of the entire system. But it's an open question whether or not that's going to happen if you do that. So that's not a given. So it's still possible, of course, that you prove no effect, or that even that you prove negative effect. And here you can see that there's a research benefit that's probably really large here, because it's would be a fantastic example of evidence-based health policy to actually test a health policy hypothesis in this way. I think it's never been done in this ambitious way. So the research benefit would be quite large. But now it's more unclear how we should think about the research benefit in relation to the cost, especially if the costs are incurred by the health system and not by the research budget of the government, for instance, or by universities. So how should, if the main positive output of this area, which is going on, that these things that you have all talked about, if the main positive output here is a research output, that might then result in the future of various clinical good things and so on, how should we compare that to spending that is actually then competing with healthcare investments in other areas? That's the kind of thing that this made me think about then. So the conclusion then is that the first model, the lab assisting clinic model, that can be squared with sort of standard ethical things. It's just very difficult to find and demonstrate the benefit that would justify the cost when you do a horizontal comparison to some other area of investment in the health system. So the other way around would make it easier to show some kind of benefit, but then it would be either the kind of benefit which is hard to square with standard healthcare ethical constraints, or the benefit would be mostly about research benefit. You're finding new knowledge, basically. You are producing better understanding, and that's valuable, but how then do you justify a cost that takes resources away from alternative healthcare investments, if you think it in that way? So one way of doing this would think, so I've thought only a little about that, but one way of doing it would, okay, so let's go all in consequentialist here and be utilitarian about it, and say that, well, you know, now you're assuming that there are these sectors of society and we should never move resources between them. Well, why do that? Maybe we should actually cut down on healthcare spending in order to boost research, because we're in this phase. So this is an argument you can do, but I think if you're talking about before about selling, so that's an argument I think is very hard sell to the public and to politicians and so on. So then you would have to think about some other way of justifying this enormous investment which seems to be going on. An alternative way is to say that, well, hey, we shouldn't really use healthcare resources for this. We should actually rethink the funding of this and think it's the research budget which should be the main place where costs should be allocated at the moment, until we can prove that this is something that's ripe for routine, and then we can move the cost to the healthcare budget. Thank you.